backing up. Are you recording?
Yes.
Okay, here we go. Massage echelons. Ta-da! Which means we're going to make it easier and effective. That's what we're going to do with all this stuff. You should have or will get a handout. How I've been doing these is I email people the handout ahead. Because we had our own confusion, some people signed up late. I don't even know if some people signed up and just showed up. It doesn't matter. We'll figure it out. But what you will get is a bunch of links, and they're categorized. So you've got more comprehensive anatomy and physiology, and then you've got a bunch of videos that are linked to the YouTube channel that will give you a review of everything that we're talking about and probably a lot more. So, and they're all narrated, so you can all, even Renee, who can't see them, can get stuff out of the information. So there's the torso. That's what we're going to try to concentrate on. You can take off all your limb stuff, your arm and your shoulder and your scapula and your hip. The torso is where our life exists. Now, we wouldn't be able to move around very easy, but we would be alive. So you can lose your entire pelvic girdle, your entire shoulder girdle, and you can still be alive. So when we think about working this area, we have to separate a little bit what is on the torso that's really about the limbs attaching and what is in really the torso, what's intrinsic to the torso. And those muscles are deeper, because on top of these intrinsic or specific to the torso muscles, we've got things like upper trapezius and the rhomboids and latissimus and pectoralis major, and those are all about attaching the limbs. And so when we talk about the limbs, we'll talk about those. However, because they're more surface, we have to go through those to get to the muscles that are specific to the torso. So that's a fun little visual for you. So that's just cute. Anatomy is important and physiology is important. So anatomy is the parts and physiology is the workings of the part. You can have anatomy and be dead, but you can't have physiology and be dead. Physiology is the part where life comes from. So we can study the skeletal system and muscles through cadaver dissection and that sort of thing. And it's what we touch. The anatomy is what we touch. And so when we touch it, we've got to understand, the layers of it and how the nervous system is embedded in it. So, because that's where almost everything we do has a physiological effect, is through the nervous system. So if we don't understand kind of the construct of things and where things are located, then the methods of the application don't make any sense. Everything should make sense. If you're ever reading about something or looking at something online or taking a class and it doesn't make sense, it's because they probably didn't put it in perspective as to why you would do something in the way you would do it. So, these are the muscle, this is the soft tissue. We're focusing mostly on soft tissue. But we manipulate soft tissue to stimulate the nervous system. It's really not about the muscles. They do pull in certain directions and they counterbalance each other. One group pulls, the other one pulls you back and all of that. But the effect we have is really about the nervous system. So when somebody says to me, oh, I got a problem with my levator scapula, no, you don't. You have an issue in that functional area. And that's not going to be confined just to that area either. Because we got to hold ourselves in posture wise, and our eyes have got to focus just right, and we got to change our balance when we take a step. That changes how we coordinate things, and so spot work isn't very good. And that's why I have always been a proponent of the full body approach to massage, where you sift through all the tissues and you move all the joints that are possible to move. And so something will sort. Something will sort out. Now, there are some things that can occur that we need to pay attention to. And one of those is the sliding of tissue layers. And we've got a couple of these things hanging around here. Luke found these. They're kind of cool. But this is our skin, right? If we look at this way, this is our skin. Then here's our superficial fascia, if it's embedded with that, for good insulation. It might be thicker here. Then this would be an example of a combined 3-layer, 4-layer muscle type things. But these things need to slide back and forth on each other. And if they don't, you're going to feel stiff and stuck. And so we used to think with things called myofascial release that we were breaking down adhesions, and we were changing the consistency of tissue, and you do make it more pliable, but mostly you can help it slide. And that excursion is not very big, there are little fibers that keep your skin from falling off. When you get old, those go away and your skin falls off. Things kind of go that direction. And then the other thing that when we're thinking about concepts, almost all of massage is pressing, right? Squeezing things together. But that doesn't support slide. You gotta think about lifting and scooting things back and forth. So that's a concept that is relatively new, last 20 years in the massage community, and I learned back in the 80s the whole myofascial release stuff with the long poles and holding things, and then I wouldn't do it like that. Now, I'd put a suction cup on it. Some sort of decompression, something that would lift that tissue, gives me a handle to lift, because that separates these layers. At least the first 2 or 3, you can get some separation on. And then if you move those somehow, move them in a directional way or in a twisty way, and you have the person move these layers, the muscle layer underneath, then you can take that gliding approach even deeper. That's why you gotta move the body. They don't have to move it. It's nice if they, there are some things where they do it, but if you fix tissue or hold tissue in a certain way or lift it and then have them move underneath, you're getting more of that sliding to occur.
A phrase that's being used more is this concept of congested tissue. Anybody heard that as a term? The area is congested, something like that. It's not the worst term in context, just because if something's congested and the liquid or the tissue has been still for longer, then things do thicken up. So there's something to, you make things warm, you move them, they become more pliable, and they liquefy. It's that viscoelasticity, right?
Yeah.
So, and the one frame of reference that we'll come back around to is the mimic normal piece. How does the body usually sustain this? Well, through regular movement. So other systems of movement like yoga, Tai Chi, systems that have you move each body region in multiple planes, that's how the connective tissue system would naturally distribute this lubricating fluid and keep it pliable. Thus, why not incorporate joint movement in massage?
Well, and we sit. You're sitting right now. And so we don't have, Luke mentioned planes of motion. That's actually a better way to understand stuff. So there are flexions and extensions that function in the sagittal plane. This is how we move. All right? And then we have movement in the frontal plane. That's mostly about balance. So if you do a jumping jack, you're moving on the frontal plane, but we don't go around the world doing, we don't do that. When we move from place to place, we're functioning, we pick something up, we reach for something. That's all in a flexion extension concept. So our flexor muscles and our extensor muscles have the bulk of our movement. They need to push and pull back and forth. They have to have longer excursions of movement. And if you look at the muscles, we'll come back and look at that in just a minute, they're more up and down and they're longer, tubular. But the muscles that are on the frontal plane, they're more triangular shaped. And they're really about holding you stable, because when you start to walk, you're on one foot. So you got to be able to hold yourself up. So that's abductors and adductors. But because we don't run around abducting and adducting, right? That's just not what we do unless you're a gymnast or something. Those muscles must have another primary function, and it is not so much pushing and pulling, creating movement, but it is contracting to stabilize a joint. And that starts at the abdominal and low back area. And some anatomists consider the adductor muscles in our legs part of our abdominal balance structure. And if you've seen anybody that has trunk weakness, cerebral palsy is an example. You'll often see this knees together kind of gait, and that's how they're getting their stability when the abdominal area won't do it. Also, you'll get a shuffle gait. You'll get where you're never standing on one foot. Now that becomes dangerous. Who we got? There they come. That becomes, it's a child. What are we going to do about it?
She's leaving.
We'll put you under a table. What do you think?
Quick sidebar, I had misspoken. It's the term is thixotropic.
Yes.
For when the nature of and this is just a matter of physics, when things are warmer and they move, but movement also creates warmth, they become more fluidy, become more elastic, more pliable.
You can come sit with me, Mom. Come here.
Yeah, there's plenty of room. So if you need to sound fancy, but I just needed to edit myself.
Yeah, did you?
Thixotropic, there you go.
There's a lot of words.
But it's just the quality of connective tissue and the sliding of layers that we need to think of that construct more so than this idea of mechanically holding the duct tape and changing the shape of the duct tape.
That's old thing.
Maybe the duct tape or the saran wrap just needed WD-40.
Yeah. And the WD-40 was there, but it was kind of pulled over here, and so the combination of us manually sliding tissue, lifting it, having them move underneath is a way of creating that ability for tissues to move against each other. It would be like if your clothes were taped to you, that would be not comfortable. You want to make sure you can get some room in there. So that's what we're looking for. And the sensation people have is they're stiff. And they get that in the two places in the torso where people feel stiff is here in their low back and up here in the upper cervical area. And the third place would be here in the anterior chest. So when we start to think about what symptoms people come with, the words they use to describe it are really important. The things that they do are really important. So sometimes people will come in and they'll say, I really need my back stretched, as they are bringing their arms back behind them, which is telling you that they're feeling short in the front. And as we continue to look at patterns here, most of the distress signaling that people experience is not from the short tissue, it's from the long tissue. So when you look at somebody's posture, if I bend forward here, I'm forward like that, I'm not going to necessarily feel it in the front with my chest. I'm going to feel it where you see the tautness in my shirt across my back. Massage is excellent at making short things long. It's not great at making long things short. So if the person has the symptom between their shoulder blades where they feel stiff, like my shirt right here, and they want you to massage it, what have you done? You've made it longer, which means this has got to get shorter. Now that's not gonna, so people aren't gonna like that if you say, oh no, it's not back there. You gotta do something. You gotta change the sensation some. So you massage it, but your intention is to override the signaling that is uncomfortable for them. So one of the big mistakes in the massage world is too much focus on the back for this very reason. But that's where people have the symptom. So two ways to deal with that are methods called hyperstimulation analgesia and counter irritation. You massage the area, you give it a lot of sensation, you pull on it, you press on it, you twist it, you do all of that so that they're feeling different. Not that they're getting any kind of a structural change per se.
A visual analogy I sometimes want to create is that even the idea of something being pulled taut.
Make sure you're in the camera, child.
I am. So something being taut, naturally this structure is uncomfortable, right? Or it can be that somebody is just holding on, by their fingertips rather than having a more comfortable grip and hold. But the structures underneath something being pulled taut, everything's getting pressed as well. So there can be the quality of, something getting short and tight where things are kind of getting bunched together, but the neural receptors, the proprioceptors and other sensory receptors there are crowded. They don't have as much a sense of being crushed and pressed on. So it's the idea of thinking there's things that can get stuck short or stuck long. If somebody's posture is shifted in such a way where the anterior chest is short for long enough, then the connective tissue structures will kind of cement down like that. And the same thing being on the reverse side where things are long. What you have is a bunch of stuff pressed down and squashed, and that can get stuck that way relative to the connective tissue sliding. Thus, it's trying to figure out what tools do we utilize. Ideally, we deal with the cave and the short stuff so that this then has some kind of recoil and some breathing room again. But we may need to come back here and find some way to take this trapped, compressed tissue and maybe lift it again. But the visual.
Yeah, and the more that we understand, because that's very contrary to the way we used to think about massage. You mentioned the word deep tissue, for example. And I've never known what that was. But it's always about a press down. Rarely is that the issue. It's more of they're feeling this tautness, and when we look at posture related to the torso, we want to think about, Luke mentioned it, what is the posture looking at? Where have they shortened? When you look at them, they'll have a cave. And then somewhere directly opposite or above it or below it, they'll have a hill. And then underneath or above a hill, they'll have another cave. So the body will adapt and compensate to this, but then you end up with non-optimal postures. And symmetrical posture where everything is lined up is not that important. You can be crooked and be just fine. But the more crooked you are, the more likely that you're going to have compensation patterns and your movement will be different. So I've got a funky knee. In order for it to feel fairly stable, it's always flexed just a little bit. That's resourceful compensation. But it changes, that makes that a short leg. All right, so it changes, I gotta kind of get myself like this a little bit. And so it's the compensation lots of times that we're gonna wanna focus on. So that's where having an understanding a little bit of the generalized organization of tissues and the not so much individual muscles. I don't care if you know the names of any of these things, except those of you that got to take the MBLEX exam. Well, I want you to understand the function and the relationships. And after you take the MBLEX exam, it doesn't matter if you remember all the individual names, but you still have to hold on to the functions and the relationships. So another plane of motion that we have in here is transverse plane where we twist. And very rarely do we just move when we're moving in flexion and extension. There's almost always a twist involved with it. Little twists along the spine, little tiny ones cumulatively. They accumulate and allow for a bigger movement. The shoulder girdle and the pelvic girdle, which are not our focus, but they have to twist. We have to be able to twist in the lumbar area, because when we move forward, if we didn't twist back, then we would just keep going in that direction. So, and our reflexes are set up so that our eyes are forward and with the sagittal plane, with the horizontal plane out there. So when I go to take a step, I carry my pelvis with me, but I twist in my lumbar area, which is part of our focus, so that I'm facing straight again. And when I take another step, everything, it reverses. So we've got to look at these transitional areas that have a lot of their movement on the transverse plane. And those areas in the torso are base of the neck, cervical C7 right here at where the neck joins the shoulder, T12, L1, the lumbar spine in general. Those are the areas in the torso where we are going to have the most what they call shear stress, because when you twist something, you get things that rub together. And that's the common areas. So they're common areas for wear and tear, disc dysfunction, that sort of thing, is where we move on the transverse plane. So this picture right here is just giving you a sense of the structures of the muscles in the torso area. If you see something that goes up and down, like rectus abdominis here, you know that that's functioning on the sagittal plane. If it connects totally within the structures of the torso, it's considered intrinsic. I started to bring this to your mind a little bit. If it goes from the torso to another structure like the arm, then it is extrinsic. And it's going to be functioning with limbs. It's about limb function. My arms go back and forth, or they turn in or out, or I move my leg or something like that. So we have to, if we're thinking about targeting the muscles of the torso, we have to remember that we have to go through that layer. Now, a lot of these muscles that attach into the torso often function with breathing. So anterior serratus, this one that's here on the side and comes around, it's really about moving the scapula and stabilizing the scapula, which is part of the upper limb. But because it attaches on the ribs, it also is going to, anything that has an attachment on the ribs is going to function with breathing. So if somebody is asthmatic, or they've had the flu, or they've coughed a lot, or whatever, they're going to feel the tension in their torso, but it might be an extrinsic muscle. The relationship is because it's attaching on the ribs. So when you look at all of the videos and stuff that I will email you or have emailed you, you want to differentiate that. It could be a torso function, like breathing, because you've got one end of it stuck on the ribs. Now, what I want to do with you is kind of help mentioning these limb muscles, but I want to concentrate our methods on the intrinsic ones. Sometimes we won't be able to just do that, but the ones that are between the ribs, and the ones that attach the head and neck to the ones that go along the spine, and those kinds of muscles often are not paid attention to. So there's a face. Cute, huh? It's cute, Renee.
Okay. Take your word for it.
But what we want to pay attention to is where torso muscles come in and attach onto the skull and into the scalp. Because your head and your neck are part of what we're thinking about when we talk about non-limbs for the massage. One of them that actually is attaches onto like the clavicle, which is part of your appendicular skeleton, which means it's a limb. But it also attaches onto the manubrium, right here, the sternum, which is a bone of the torso. That's the sternocleidomastoid. Is, again, one of those muscles that has lots of jobs. Is it stabilizing the clavicle? Is it lifting the clavicle so it'll move when we raise our arm? Is it holding the head up so that we can see with the horizontal plane? Is it part of our breathing because it's down here on the rib cage? Those are muscles that will often increase in tone and be symptomatic. And so that's one that you will see a lot of symptoms arise from, a lot of headaches, a lot of neck stiffness. But there are muscles underneath it that often get ignored. And then there are the extrinsic muscles, the trapezius primarily, that attach up onto the skull And so those also have to be thought of as doing double duty. So this picture right here is a little bit more about the intrinsic muscles. We've got a little bit of overlap in it, but when you look at this, you see the muscles that go up and down the spine, the erector spinae. Sometimes they call those the strap muscles, and then they go on up and end up becoming capita cervicis and all that, come up and they attach into the skull. This whole line right through here. And then we have some muscles that go crosswise that are part of the stability and also involved in breathing, and those are your serratus posterior, superior, and inferior. And those are ones that will get real angry when somebody is coughing or sneezing a lot, or their upper chest breathing. And if a muscle goes horizontal, like these kind of do, the ones that twist us, they're almost impossible to stretch. Their movement is not very big. You can stretch, elongate most muscle structures that function in the sagittal plane. They're long, and they got a lot of movement attached to them. Little less so in the frontal plane, ones that adduct and abducts. But it's almost impossible to manually stretch internal and external rotators. And they're deep down. So you can't just stretch deep stuff. You got to also elongate all the stuff on top of it. And usually you get stopped by stiff tissue or another muscle or a discomfort response, or you bump into a joint, the joint bumps into itself. You usually get stopped before you can get enough elongation, tension force on these deeper muscles. Fortunately, they do press out. This is one place where compression is helpful. So most of the time when people struggle giving deep pressure, or people ask for more pressure, they're asking for it along these strap muscles of the spine. And those muscles are located in a terrible place for us to get good body mechanics on it to do that. So one of the things we want to make sure we do is show you how to get to that, so that you can give them the sensation that they want without hurting yourself. I rarely get anybody that asks for, or I hear of anybody asking for more pressure on the legs or the calves. It's almost always that strip along the back. Has anybody got any other place where clients will ask for more pressure? No, so you're killing yourself to try to satisfy a sensation need. So that's one of the things that we want to make sure we try to help you with.
And potentially some of the symptoms manifesting from the rib cage as a whole not functioning appropriately. So
Yes.
How can you maybe distort that structure as one, as opposed to trying to dig? Like, I haven't, very rarely can I think of a moment I've tried to go after an intercostal specifically, rather than thinking of the whole rib cage as a unit.
So, and that's exactly where I was going. So we've got this bigger line that goes up and down the spine, the erector spinae group, and then we got this smaller line, multifidi rotators. They're more attached between individual spinous processes and onto the ribs. And then we've got the intercostals that Luke just mentioned. and you can dig your fingers in between those ribs. You can do that. But you're going to get further along if you change the shape of the rib cage by compressing it and having them twist. You know, and this is where side lying is really essential, is because we get a lot of force on our chest, our rib cage. We lay on our back, we lay on our stomach, but we don't get a lot of compressive force or a lot of movement in the lateral sides of us. And so if you just move those joints rhythmically by just compressing and letting go of the rib cage when somebody is in side-lying position, you're managing a whole bunch of stuff in there, and I rarely see that done. It's something I have always done, but I don't very use, well, there are restrictions in Hand and Stone, they're not the only one, but they have restrictions on working on the torso. Yeah, you can't, and they're afraid that somebody is going to say they were inappropriately touched, and they don't want to get a lawsuit against them. So if somebody comes in and they've got symptoms in their mid-back and that sort of thing, and you can't access you don't use side-lying position, because they don't use that either. You do. You can't access the area. All right, I'm going to show one or two more pictures here, and then we're going to take a break. So this is the abdominal stuff that we have in the torso. The squishy stuff is located below the diaphragm, so the liver and the stomach and the intestines and all that. And then above it, protected in the rib cage, we have the heart and the lungs. So that's another area that doesn't get massaged. But your whole low back starts at your belly button. It goes the whole distance around there. So this is a good spot to take a break, and why don't we take 15 minutes.